All providers who administer vaccine must have a thorough understanding of contraindications and precautions to vaccination. We include fairly detailed information about contraindications to vaccination because this is a common topic of questions we receive. From a practical standpoint, you know that when a contraindication or precaution to a vaccine is present, you usually do not give a dose of that vaccine. But let's define these terms a little more precisely. A contraindication is a condition in a vaccine recipient that increases the likelihood of a serious adverse reaction to the vaccine. A contraindication is a condition in the recipient, not with the vaccine itself. If the vaccine were given in the presence of that condition, the resulting adverse reaction could seriously harm the recipient. The risk of an adverse reaction outweighs the benefit, so you will rarely, if ever, give a vaccine when one of these conditions is present. A precaution is similar but not identical to a contraindication. A precaution is a condition in a recipient that might increase the chance or severity of an adverse reaction, or a condition that may compromise the ability of the vaccine to produce immunity. Injury from the vaccine could result, but the chance of this happening is less than with a contraindication. Generally, you will not give the vaccine if a precaution is present, but there may be situations when the benefit of the vaccine outweighs the risk of an adverse reaction, such as during an outbreak of the disease. In these situations, you may decide to give the vaccine. There are very few true contraindications and precautions, so let's go through them briefly. There are 4 permanent contraindications to the use of routine vaccines. The first, which applies to all vaccines, is a severe allergic reaction to a vaccine component or following a prior dose of vaccine. By severe, we mean an allergic reaction that is immediate and life-threatening, also called anaphylaxis. The second applies to pertussis-containing vaccines only. It is encephalopathy within 7 days of a prior dose of pertussis vaccine. The third permanent contraindication applies only to rotavirus vaccines. It is a history of intussusception. This contraindication was added in 2011 because infants who have developed intussusception appear to be at higher risk of another episode of intussusception. Also, some studies suggest that infants who receive rotavirus vaccine are at increased risk of intussusception. We will discuss this issue in more detail in the rotavirus module of the program. The fourth permanent contraindication also applies to rotavirus vaccines only. Any rotavirus vaccine is contraindicated for an infant who is diagnosed with the rare disease severe combined immunodeficiency, or SCID. There are other permanent contraindications for vaccination that are not routinely recommended. For example, for smallpox vaccine, a history of eczema or atopic dermatitis in the person or a household contact is a permanent contraindication to pre-event vaccination. Joellen.
There are several other conditions that are temporary contraindications or precautions, and whether a condition is a contraindication or precaution depends on the type of vaccine being used, live or inactivated. Here is a table that lists the conditions. The C indicates a contraindication, P indicates precaution, and V means vaccinate if indicated. A severe allergic reaction to a vaccine component or a prior dose of vaccine is a contraindication to both live and inactivated vaccines. Encephalopathy following a prior dose of pertussis vaccine is a permanent contraindication that applies to pertussis-containing vaccines in all age groups. Pregnancy is a contraindication to live vaccines because of the theoretical possibility of infection of and damage to a fetus. No vaccines except smallpox vaccine has ever been shown to actually damage a fetus. Since inactivated vaccines do not replicate, they may be used if indicated. There are exceptions to this. Pregnancy is considered to be a precaution for human papillomavirus vaccine. We will discuss this in more detail in the HPV module of the series. Pregnancy in a household contact is not a contraindication to any vaccine except smallpox vaccine. Immunosuppression is a contraindication to most live vaccines. Although severe combined immunodeficiency is a permanent contraindication to rotavirus vaccine, immunosuppression from other causes is considered to be a precaution to rotavirus vaccine. Inactivated vaccines may be administered to immune-suppressed persons if indicated. We will discuss immunosuppression in more detail in a moment. Moderate or severe acute illness is a temporary precaution to both live and inactivated vaccines. It is reasonable to defer vaccination until the acute condition has improved. So what do we mean by moderate or severe? As a rule of thumb, any illness that may require hospitalization or additional medical care after the immunization visit is a reason to delay the vaccine. The ACIP has never recommended a maximum temperature for giving vaccines. Fever is not always a reliable indication of a severe illness, especially in children. Children can often be mildly ill with a fever or moderate to severely ill without a fever. Clinicians need to look at the complete clinical picture and use professional judgment about the severity of the acute illness. Minor illnesses, with or without low-grade fever, are certainly not reasons to defer vaccination. Recent receipt of blood product is a precaution to MMR and varicella vaccines because of the possible interference with viral replication. Recent blood products have little or no effect on inactivated vaccines. This is a good example of the difference between a contraindication and a precaution. Giving measles vaccine shortly after a blood transfusion will not harm the vaccine recipient, but the antibody will probably inactivate the vaccine virus, and no immunity will result from the vaccination. Recent blood products do not affect all live vaccines equally, and some are not affected at all. Circulating antibody does not appear to affect zoster vaccine, probably because the large amount of varicella zoster virus in the vaccine can overcome antibody in the serum. Antibody does reduce the response to rotavirus vaccine, but the effect of the antibody is less because the vaccine is administered by mouth. Passive antibody does not affect live attenuated influenza vaccine because the vaccine viruses are often changed from year to year. Antibody against a previous year's vaccine virus does not affect the current year's virus. Finally, few North Americans have antibody to yellow fever or typhoid, so there is little or no antibody against these pathogens in the U.S. blood supply. These vaccines can be administered simultaneously with blood products or separated by any interval. Donna?
We receive many questions about vaccination of immunosuppressed persons, so we would like to discuss this in a bit more detail. An immunosuppressed person may be more likely to have a serious adverse reaction to a live vaccine than a person with a normal immune system. There are both diseases and drugs which can cause significant immunosuppression. First, the diseases. Persons with congenital immunodeficiency, leukemia, lymphoma, or generalized malignancy should not receive live vaccines. Certain drugs and therapies may cause immunosuppression. For instance, people receiving cancer treatment with alkylating agents or antimetabolites or radiation therapy should not be given live vaccines. Live vaccines can be given after chemotherapy has been discontinued for at least 3 months if the disease for which the therapy was given is in remission. Persons immunosuppressed from disease or chemotherapy may not respond well to inactivated vaccines, and live vaccines can be harmful to them. However, in the absence of a bone marrow transplant, neither the disease nor chemotherapy for the disease eliminates the immunologic memory of vaccines received before the disease or therapy. As a result, it is not necessary to revaccinate a person who has recovered from an immunosuppressive disease or chemotherapy. Persons receiving large doses of corticosteroids should not receive live vaccines. This would include those receiving 20 milligrams or more of prednisone daily or 2 milligrams or more per kilogram of body weight per day. Aerosolized steroids such as inhalers for asthma, topical preparations, alternate day or short high-dose courses are not contraindications to vaccination. Short-term means less than 14 days. For people who have received high-dose steroids for more than 14 days, you should wait at least a month after discontinuation of therapy before administering a live virus vaccine. There are a variety of new drugs considered to be immune system mediators or modulators. Examples of these drugs include interferons and etanercept, a tumor necrosis factor blocker marketed as Enbrel. It is not known if or at what dose these drugs may cause safety concerns for live vaccines. Until more information is known about these drugs, we recommend they be treated like high-dose steroids. Defer live vaccines for 1 month after discontinuation of therapy. Inactivated vaccines may be administered. Persons with HIV infection who are mildly immunosuppressed and not severely symptomatic should receive measles, mumps, rubella vaccine. This is because of the high risk of complications of measles disease in these persons. The ACIP also recommends that monovalent varicella vaccine be administered to persons with HIV infection with adequate CD4 T-cell counts. MMRV, zoster, live attenuated influenza vaccine, or LAIV, and smallpox vaccine should not be given to persons with HIV infection regardless of symptom status. HIV infection is a precaution to the use of rotavirus vaccine. All inactivated vaccines may be administered to a person with HIV infection if indicated. Inactivated vaccines may be administered if indicated to any immunosuppressed person, but response to the vaccine may be poor. A good immune response to an inactivated vaccine requires a relatively functional immune system. So the person may not be fully protected even if the vaccine has been given. But a little protection is better than none at all if you do not administer the vaccine. Andrew?
One additional issue related to immunosuppression is the vaccination of persons who have received a hematopoietic cell transplant, or HCT. HCT includes bone marrow transplant. Research has shown that antibody titers to vaccine-preventable diseases decline during the 1 to 4 years after HCT if the recipient is not revaccinated. It has been common practice in transplant centers to revaccinate HCT recipients, but vaccination protocols varied widely among centers. In 2000, CDC published guidelines for prevention of opportunistic infection, including vaccine-preventable infections, among hematopoietic cell transplant recipients. These guidelines were developed in association with ACIP, the Infectious Diseases Society of America, and the American Society of Blood and Marrow Transplantation. In 2009, CDC, in association with several professional organizations, published updated recommendations in the journal Biology of Blood and Marrow Transplantation. An activated influenza vaccine should be administered prior to HCT if possible. The routine recommendation is to give a dose of inactivated influenza vaccine 6 months following transplantation. The dose can be given as early as 4 months following the transplant. A second dose should be considered in this circumstance. The inactivated vaccines Hib, meningococcal conjugate, inactivated polio, hepatitis B, and a tetanus toxoid-containing vaccine should be initiated 6 months after the transplant. The previous recommendation was a 12-month interval between transplant and most vaccines. Because HCT recipients have their immune memory erased as part of their treatment, they may benefit from the higher antigen content of diphtheria and pertussis antigen in DTaP vaccine. This vaccine is not licensed for persons older than 6 years, but providers should consider DTaP vaccine as an initial primary series for these older persons. This can be followed by a dose of Tdap as a booster, with TD thereafter in the routine 10-year cycle. Tdap does not produce a strong immune response to tetanus and pertussis toxoids when used as an initial primary series dose in HCT recipients. A primary series of pneumococcal conjugate vaccine can begin 3 to 6 months after HCT. Providers should review the patient's risk for pneumococcal disease, as well as the 2009 document, when choosing which interval to use. The series can be followed by a dose of pneumococcal polysaccharide vaccine, or if the patient has chronic graft versus host disease, which is a complication of transplant, then another dose of pneumococcal conjugate vaccine can be administered. MMR vaccine is recommended 24 months following HCT if the patient is no longer immunosuppressed. Varicella vaccine can be considered at 24 months following transplant if the patient is no longer immunosuppressed and does not have active graft versus host disease. Revaccination with hepatitis A vaccine and human papillomavirus vaccine are optional for HCT patients. Revaccination with the live rotavirus or zoster vaccines is not recommended following HCT. An extremely important adjunct to prevention of vaccine-preventable diseases in hematopoietic cell transplant recipients, as well as other immunosuppressed persons, is to assure that family members, household contacts, and healthcare personnel are immune. Healthy, susceptible household contacts of immunosuppressed persons should receive MMR and varicella vaccines, as well as annual influenza vaccination. If you do not vaccinate the healthy person, they remain susceptible and may be infected with the wild virus, particularly varicella. A person with the disease presents a real threat to an immunosuppressed household contact. There is no risk of transmission of MMR vaccine virus to the immunosuppressed person, and the risk of transmission of varicella vaccine virus is extremely small. Live attenuated influenza vaccine may be administered to the close contacts, including household members, of immunosuppressed persons, as long as the immunosuppressed person is not hospitalized in a protective isolation or environment. Because of the risk of contact transmission, smallpox vaccine should not be given to a person with an immunosuppressed household contact. Recommendations for vaccination of immunosuppressed persons are detailed in the General Recommendations on Immunization. There is also a table that lists vaccines that are indicated and contraindicated by specific immunosuppressive condition. You will find it very useful. These documents and the complete stem cell transplant document from 2000 are available to download from the MMWR website. The 2009 HCT recommendations have been incorporated into the 2011 revision of the General Recommendations on Immunization.
The key to reducing the risk of serious adverse reaction is screening for contraindications and precautions. Every person who administers vaccines should screen every person before giving the vaccine. Contraindications to vaccination can change from one dose of vaccine to the next dose, so everyone should be screened prior to every dose, even if they were screened during a prior visit. Many states have developed screening questionnaires for use in their clinics. You can develop your own sheet, or you can adapt one that has already been developed. The Immunization Action Coalition has developed good one-page screening sheets for both children and teens, as you see here, and for adults. They list all screening questions that need to be asked. The form can be completed by the parent while waiting to be seen. On the back of the form, there is a paragraph explaining why each question is being asked. There is a very helpful feature and reminds staff why they are asking these questions in the first place. Effective screening is not difficult or complicated. It can be accomplished with just a few questions. It is important for you to understand the reasons for the questions on the screening form. So we would like to take a few minutes to review them and the rationale for asking them. The first question is simple. Is the child sick today? The first question addresses whether the child has a moderate or severe acute illness, which is a precaution to vaccination. If the child has been examined, this question may not be necessary or already may have been answered. There is no evidence that acute illness reduces vaccine efficacy or increases vaccine adverse reactions. But with moderate or severe acute illness, vaccines should be delayed until the illness has improved. This avoids confusing a symptom of the illness, such as fever, with a vaccine adverse reaction or vice versa. Mild illness, such as otitis media or an upper respiratory infection, is not a contraindication to vaccination, nor is taking antibiotics a reason to withhold a vaccine in a person who is otherwise not very sick. The second question is, does the child have an allergy to any medication, food, or vaccine? A severe allergic reaction to a vaccine or a vaccine component is a contraindication to subsequent doses of that vaccine or to a vaccine containing that component. For instance, an anaphylactic reaction to eggs is a contraindication to influenza vaccine. We suggest that you inquire about allergies in a generic way rather than read the parent a list of every component of every vaccine. Most parents will not recognize most of the components anyway, but they will know if the child has ever had an allergic reaction severe enough to seek medical attention, which is what you are trying to find out. If you do identify a person who has had a severe allergic reaction to a product that may be in a vaccine, the next challenge is to figure out which vaccines might contain the product. To make this text easier, you need a listing of the vaccine components. A comprehensive table of vaccine components, also called excipients, is available from the Updates and Resources webpage and in an appendix of this course text. Remember that a local reaction, such as redness or swelling at the site of injection, is not a contraindication to subsequent doses of that vaccine. A third question is, has the child had a serious reaction to a vaccine in the past? This open-ended question is intended to identify allergic reactions following previous vaccine doses. It can also help to identify conditions following pertussis vaccine. Usually vaccines are deferred when precautions are present, but situations may arise when the benefit of the vaccine outweighs the risk. For instance, a child who had a temperature of 105 following a prior dose of DTaP might still be vaccinated if there were an outbreak of pertussis in the community. There are other adverse reactions that might have occurred following vaccination that create contraindications or precautions to additional doses. We will discuss these in more detail when we talk about the individual vaccines. The fourth question is, has the child had a seizure, brain, or nerve problem? A history of encephalopathy within 7 days following whole-cell DTP or DTaP vaccine is a contraindication to DTaP and Tdap. An undiagnosed neurologic problem is a precaution to the use of DTaP and Tdap. For children with a stable neurologic disorder, including seizures unrelated to vaccination, or for children with a family history of seizures, you should vaccinate with DTaP or Tdap as usual. A personal or family history of seizures, in a sibling or parent, for instance, of any etiology, is a precaution for MMRV vaccination. A history of Guillain-Barré syndrome occurring within 6 weeks of tetanus-containing or influenza vaccine is a precaution to additional doses of these vaccines. The fifth question is, has the child had a health problem with wheezing or asthma, lung disease, heart disease, kidney disease, metabolic disease such as diabetes, or a blood disorder? This question is to identify possible contraindications to one of the 2 types of influenza vaccine. Children with any of these health conditions should not be given the intranasal, live attenuated influenza vaccine. These children should be vaccinated with the inactivated injectable influenza vaccine. Donna?
One of the most important conditions to identify during screening is the presence of immunosuppression. Since many different conditions and therapies can produce immunosuppression, there are 2 screening questions to probe for this. The first is, does the child have cancer, leukemia, AIDS, or any other immune system problem? Live virus vaccines, such as MMR and varicella, are usually contraindicated in persons with severe immunodeficiency. However, MMR and varicella are recommended for persons infected with HIV who do not have evidence of severe immunosuppression. Varicella vaccine is contraindicated in persons with cellular immunodeficiency, but may be administered to persons with humoral immunodeficiency. All inactivated vaccines may be given to immunosuppressed persons, although the response to the vaccine may be suboptimal. Also remember that having an immunosuppressed person in the household is not a contraindication to vaccination of a healthy child. The next question is also related to immunosuppression. Has the child taken cortisone, prednisone, other steroids or anti-cancer drugs, or had X-ray treatments in the past 3 months? High daily doses of corticosteroids for more than 14 days can cause significant immunosuppression and increase the chance of an adverse reaction following a live vaccine. Live vaccines should not be administered for at least 4 weeks following prolonged high-dose steroid therapy or for at least 3 months following cancer chemotherapy. Persons receiving aerosolized steroids, such as inhalers for asthma, topical preparations, or low or moderate daily or alternate day doses of steroids for fewer than 14 days can receive live vaccines during treatment. As with other immunosuppressive conditions or therapies, inactivated vaccines may be administered to a person receiving high-dose steroid therapy, although the response to the vaccine could be reduced. The next question probes for recent receipt of antibody-containing products. Has the child received a transfusion of blood or blood products or been given a medicine called immune or gamma globulin in the past year? Passively acquired antibody may reduce the effectiveness of MMR and varicella vaccines. MMR and varicella vaccines generally should not be given to persons who have recently received antibody-containing blood products. This question might also uncover unreported illnesses that might not have been revealed in earlier questions, since blood products are usually given for specific indications. Depending on what product was administered and the dose, it may be necessary to defer MMR and varicella vaccines for up to 11 months after the blood product. Rotavirus, LAIV, and zoster vaccines are exceptions to these recommendations. These live attenuated vaccines can be given at any time before, after, or simultaneously with an antibody-containing product. Table 5 in the 2011 General Recommendations on Immunization lists the most commonly used antibody-containing preparations in the United States. It also lists the recommended waiting period between the blood product and administration of MMR or varicella vaccine. Every office should have a copy of this table, which is included in the course text and on the resources webpage. This issue is discussed in more detail in the General Recommendations segment of this program. The next question is the child or teen pregnant, or is there a chance she could become pregnant during the next month? This question should be asked of all females of childbearing age, including young adolescents. MMR and varicella vaccines are contraindicated within 4 weeks of and during pregnancy due to the theoretical risk of virus transmission to the fetus. Sexually active females who receive MMR or varicella vaccine should be instructed to practice careful contraception for 1 month following receipt of either vaccine. With the exception of human papillomavirus vaccine, inactivated vaccines may be given to pregnant women when indicated. It is not necessary to inquire about pregnancy in household contacts. Having a pregnant woman living in the household is not a contraindication to administration of any vaccine to other household members except smallpox. The final screening question is, has the child received any vaccinations in the past 4 weeks? The intent of this last question is to identify persons who recently received a live virus vaccine. The Advisory Committee on Immunization Practices recommends that 2 live virus vaccines not given on the same day be separated by at least 4 weeks. If the vaccine given recently was an inactivated vaccine, such as DTaP or hepatitis B vaccine, it is not necessary to defer any vaccine. In addition to the child and teen screening form, the Immunization Action Coalition has developed a screening form for adults. It contains many of the same questions that are on the child and teen form. The Immunization Action Coalition has also created a guide to contraindications and precautions to commonly used vaccines. This table, as well as the child and adult screening forms, can be downloaded from the IAC website at www.immunize.org. Print and post the contraindication guide to have handy when screening for and giving vaccines. Regardless of what form you use, the important thing is that you ask these questions before administering vaccines to people of any age. Your patients are depending on you to make vaccines as safe as they can be. Screening every patient at every visit is one way to do this.
The risk of an adverse reaction following vaccination can be greatly reduced with consistent and thorough screening for contraindications and precautions. However, despite screening, adverse reactions will still occur. In this section of the program, we would like to present an overview of the general types of adverse reaction. Let's begin by defining our terms. The intended effect of a vaccination is to produce active immunity to specific antigens. An adverse reaction is an unwanted extraneous effect caused by a vaccine. A synonym of adverse reaction is vaccine side effect. A vaccine adverse event, on the other hand, refers to any event that occurs following a dose of vaccine. So an adverse event may be a true adverse reaction, or it may be only coincidental, with further research needed to distinguish between them. This terminology may be new to you and is not meant to be confusing. It is meant to increase the precision of discussions of vaccine safety. Adverse reactions are known to be caused by the vaccine. Adverse event is a more generic term that does not necessarily imply a cause and effect relationship with the vaccine. Vaccine adverse reactions fall into three general categories: local, systemic, and allergic, listed here in order of decreasing frequency and increasing severity. The most common type of adverse reaction is a local reaction, such as pain, swelling, and redness at the site of injection. Local reactions may occur in up to 50% of vaccine doses, depending on the type of vaccine. Local reactions are most common with inactivated vaccines, particularly those that contain an adjuvant, such as DTaP and pneumococcal conjugate vaccines. Local adverse reactions generally occur within a few hours of the injection and are usually mild and self-limited. Occasionally, local reactions may be exaggerated. Some people refer to these as hypersensitivity reactions, but this is a misnomer since they are not allergy-mediated, as the term implies. These reactions are properly known as Artus reactions and are most commonly seen after tetanus and diphtheria toxoids. They are believed to be due to a very high concentration of antibody in the vaccine recipient, usually because of too many doses of toxoid in too short an interval. A second type of adverse reaction is referred to as systemic. These are more generalized symptoms and include fever, malaise, headache, myalgias or muscle pain, loss of appetite, and others. You may notice that these symptoms are common and nonspecific and may occur in a vaccinated person because of the vaccine, or may be caused by something totally unrelated to the vaccine, like a concurrent viral infection. Systemic adverse reactions were relatively frequent with whole cell bacterial vaccines like DTP. However, they are less common following inactivated vaccines currently in use, including DTaP. We know systemic adverse reactions are not common because of the studies that compare vaccine and placebo recipients. The rates of systemic reactions are often similar in both groups, indicating that few of the reactions are actually due to the vaccine. Systemic adverse reactions from live vaccines are a different situation. Live attenuated vaccines must replicate in order to produce immunity. The symptoms you would expect as a side effect following live vaccines are basically those associated with a mild case of the disease. These adverse reactions occur after an incubation period of the virus, which is 7 to 21 days for MMR and varicella. As an example of systemic adverse reaction to a live vaccine, consider measles. The most common symptoms of measles disease are fever and generalized rash. These symptoms in a milder form are also the most common adverse reactions following measles vaccine, occurring in 5 to 10% of recipients. An exception to this general rule is smallpox vaccine. Smallpox vaccine does not contain attenuated smallpox virus. It contains vaccinia virus, which is the same family as smallpox virus, but causes a much less severe illness. So the symptoms of smallpox vaccine are not like a mild case of smallpox. They are symptoms of infection with vaccinia virus. A third type of adverse reaction is a severe allergic reaction. The allergic reaction may be caused by the vaccine antigen itself, or more likely by some other component of the vaccine, such as cell culture material, stabilizer, preservative, or antibiotic used to inhibit bacterial growth. Severe allergic reactions to vaccines are rare, occurring at a rate of less than 1 in 500,000 doses, but they may be life-threatening. The risk of an allergic reaction can be minimized by good screening prior to vaccination. Some adverse reactions do not seem to fit into 3 categories of local, systemic, or allergic. For instance, thrombocytopenia after measles vaccine, encephalopathy after whole cell pertussis vaccine, and Guillain-Barré syndrome after the 1976 influenza vaccine. Reactions like these are obviously not local, and they are not allergic in the typical sense, so they could be classified as systemic reactions. They are rare occurrences and are specific to one vaccine. We will discuss these unusual adverse reactions again when we discuss the specific vaccines. So to review, adverse reactions can be generally categorized as local, systemic, and allergic. Local reactions are fairly common and usually mild. Systemic reactions less common, and allergic reactions are rare, but they can be severe. We will be talking about adverse reactions in more detail as we talk about the specific vaccines.
Vaccines are among the most significant public health success stories of all time. However, like all pharmaceutical products, no vaccine is completely safe or effective. While almost all known vaccine adverse events are minor and self-limited, some vaccines have been associated with very rare but serious health effects. We usually give vaccines to healthy people, including very young children, and vaccines often are required by state immunization laws. So vaccines are held to a higher standard of safety than other medications. So it is critical that we do everything we can to ensure that vaccines are as safe as possible and to maintain public confidence in vaccines. To do this, we need to monitor closely the occurrence of adverse events, evaluate possible associations, and respond appropriately to those risks. Monitoring adverse events following vaccination is especially important for newly licensed vaccines. Before licensure, vaccines undergo extensive testing and review for safety, immunogenicity, and efficacy. Pre-licensure studies, in particular phase 3 clinical trials, usually include unvaccinated comparison or control groups, so we can determine which reactions were actually caused by the vaccine. However, pre-licensure trials include a relatively small number of participants. Usually the vaccine has been given to only a few thousand people, and usually they are monitored for a limited time period. And the studies are often conducted in homogeneous populations, meaning groups that are less diverse than those in which the vaccine is ultimately used. And finally, because the number of participants is relatively small, the sensitivity for detection of uncommon or rare adverse events before licensure is low. Because of the inherent limitations of pre-licensure testing, we cannot rely on pre-licensure studies to identify all the reactions that may occur once a vaccine is more widely used. For that, we rely on post-licensure surveillance, which is the continuous monitoring of vaccine safety in the general population after licensure. The objectives of post-licensure safety monitoring are to identify rare reactions not detected during pre-licensure studies, monitor increases in known reactions, identify risk factors or pre-existing conditions that may promote reactions, identify vaccine lots with unusually high rates or types of events, and identify signals of possible adverse reactions that may warrant further study or affect current immunization recommendations. The National Childhood Vaccine Injury Act of 1986 requires healthcare professionals and vaccine manufacturers to report certain vaccine adverse events. In 1990, a reporting system was put into place to assist providers and families with this requirement. The system is called the Vaccine Adverse Event Reporting System, or VAERS. VAERS is a cornerstone of post-licensure adverse events monitoring in the United States. So it is important that you understand how it works and what it does. We asked Dr. Zani Leroy, a vaccine safety expert in the Immunization Safety Office at CDC, to tell us about the system.
Established in 1990, the Vaccine Adverse Event Reporting System, or VAERS, is a vaccine safety surveillance system created for the reporting, collection, management, and evaluation of possible adverse events following vaccinations given in the United States. VAERS was created as part of the National Childhood Vaccine Injury Act of 1986 and is co-managed by CDC and the Food and Drug Administration. Because VAERS is a large national surveillance system, it can detect rare adverse events after vaccines are licensed that may not be identified in vaccine clinical trials. This segment describes VAERS, who can report and how, and what happens after a VAERS report is submitted. I will also give examples of how VAERS can be used and has detected adverse event signals in the past. VAERS is the nation's frontline vaccine safety surveillance system. Anyone can report a vaccine adverse event to VAERS. The system relies on healthcare providers, as well as patients, caregivers, and manufacturers, to report adverse events that are possibly related to vaccination. Adverse events are health effects that occur after immunization that may or may not be causally related to a vaccine. By including all health conditions that occur around the time of vaccination, VAERS can look for new or previously unrecognized health events or very rare conditions that people may have not associated with a vaccine. We are often asked what adverse events should be reported to VAERS. Any post-vaccination medical occurrence that is of concern to you, the patient, or family member should be reported, even if you are not certain that the vaccine caused the event. The Childhood Vaccine Injury Act requires healthcare providers to report adverse events following immunization that are listed on a table of reportable events, a section of which is shown here. Reportable events listed on the table include events that occur within a certain period of time, such as anaphylaxis within 7 days for many vaccines and brachial neuritis within 28 days following tetanus-containing vaccines, or the occurrence of any reaction to a vaccine which is specified in the manufacturer's package insert as a contraindication to additional doses of the vaccine. VAERS depends on the reporting of different adverse events following immunization, most of which are not listed on the table of reportable events. Healthcare providers are encouraged to report any clinically significant or unexpected event that occurs after receipt of any vaccine. Now let's talk about how VAERS works. Many vaccine providers have heard of VAERS and have seen a copy of the VAERS reporting form shown here. The form collects demographic information about the patient and the reporter of the adverse event and should include as much detail as possible. Reporting through a secure website is preferred and encouraged. Users may find this a very convenient way to submit a VAERS report. Online reporting also shortens the time to receive and process the report. Paper forms are also available from the VAERS website at vaers.hhs.gov or by calling the toll-free VAERS telephone number found on every vaccine information statement. The completed form can be faxed to a toll-free number or mailed to VAERS, postage paid. Once VAERS receives a report, a letter is sent to the person who submitted it. The letter provides the assigned VAERS ID number and may request additional information. a team of healthcare professionals conducts follow-up to obtain more information on reports of serious adverse events. Adverse events are defined as serious if any of the following occurred: death, life-threatening illness, hospitalization, prolonged hospitalization, permanent disability, or a birth defect. VAERS also conducts follow-up for selected vaccines or adverse events that have been designated for enhanced surveillance by CDC or FDA. For serious reports, VAERS staff seeks to obtain missing information on the VAERS form and medical records or autopsy reports. In addition to the VAERS form, hospital, clinic summaries, or other medical records are accepted. These can be submitted with the original report or later accompanied by the VAERS ID number. Additional medical information is extremely useful in evaluating case reports and determining recovery status. While reporting to VAERS is vital, it is important to note the system's strengths and limitations. VAERS thrives because it is national in scope and collects large numbers of reports, allowing it to detect rare adverse events following immunization that were not detected in pre-licensure vaccine trials. VAERS data generates hypotheses or questions for further study. VAERS can also monitor trends of known adverse events, such as increases in known vaccine reactions or decreases in reactions when similar vaccines are compared. And VAERS is a powerful tool to monitor vaccine lot or batch safety. There are a number of limitations of VAERS data that we must also keep in mind. VAERS may suffer from reporting biases. First, underreporting is inherent to all passive surveillance systems. Second, stimulated reporting to VAERS can result from media attention highlighting a concern about a vaccine or from a specific organization encouraging members to file reports on a particular health condition. Next, not all reports are verifiable. Some reports are submitted with incomplete or missing information, including missing identifying information, making it impossible to follow up. There are also statistical limitations to VAERS. VAERS does not collect data on the number of vaccine doses administered, so actual rates of adverse events cannot be accurately calculated. Finally, it is important to keep in mind that VAERS is not designed to assess if a vaccine caused an adverse event. Coincidental events are reported to VAERS that happen at the time of vaccination and are related to other causes. VAERS does not make an evaluation of whether reports are caused by vaccine. However, these coincidental reports remain in its public searchable dataset, CDC Wonder. Let's discuss the uses of VAERS. VAERS can be used to monitor the general safety of new vaccines. During the 2009 H1N1 influenza pandemic, VAERS was key in helping to assess the safety of the H1N1 influenza vaccine. VAERS provided the first national data during the H1N1 pandemic, and this information was useful to vaccine policymakers. VAERS can also help to detect new adverse event signals. Signals are detected when the number of reports of an adverse event is disproportionately larger than similar reports after other vaccines. Signals are further evaluated by more rigorous research. For example, in 1999, a rotavirus vaccine was found to be associated with an increased risk of intussusceptions, a serious medical condition in which a part of the intestine telescopes into another part of the intestine and can result in bowel obstruction. This rare risk was identified because 15 healthcare providers took the time to submit a report to VAERS. The manufacturer voluntarily removed the vaccine from the market until further studies confirmed the finding that there was a risk for intussusceptions. Today we use an entirely different rotavirus vaccine. A condition that is not so rare is syncope following vaccination. VAERS detected a signal of an increased risk of syncope in adolescents after receiving vaccines, especially in females receiving Gardasil vaccine. This led to recommendations regarding observation of the patient after vaccine administration. VAERS data can also provide reassuring information supporting vaccine safety. For instance, in 1976, vaccination with the swine flu vaccine was associated with Guillain-Barré syndrome, or GBS. VAERS has monitored influenza vaccines every year, looking specifically at reports of GBS. The results have been reassuring, and only a few studies have suggested an increased risk for GBS after influenza vaccines since 1976. The studies suggest that if there is a risk for GBS after influenza vaccine, it would be about 1 additional case per million persons vaccinated. In another example, VAERS was able to document a decrease in the reports of fevers and seizures when the newer acellular pertussis vaccine, DTaP, first came on the market as compared to the older whole-cell pertussis vaccines. So as the cornerstone of the country's vaccine safety monitoring system, VAERS is always on call to receive reports of any adverse event suspected to be related to any U.S. licensed vaccine. There are a few important points to remember. VAERS accepts all reports of adverse events. Events that are related, as well as those that may seem unrelated to vaccination, can be reported. A report in VAERS concerning an adverse event does not prove that the event was caused by the vaccine. The event may be coincidentally related to vaccination. VAERS reports are screened and evaluated on an ongoing basis by teams of researchers at CDC and FDA. Vaccine safety concerns are identified and further assessed, as illustrated by the example of intussusception. VAERS relies on the astute healthcare provider, as well as patients and family members, to notice and report adverse events that may be related to vaccination. Your contribution to VAERS is absolutely vital. VAERS cannot work without you.
VAERS is a critical tool in CDC's vaccine safety surveillance system. However, it does have limitations. An important limitation of VAERS is its data cannot be used to determine whether a reported adverse event was caused by the vaccine. This cannot be determined because VAERS contains no information about the occurrence of medical conditions or symptoms in persons who are unvaccinated. To obtain these data, it is necessary to study a large population that contains both vaccinated and unvaccinated persons. In such a population, the medical condition or symptoms that may indicate a vaccine adverse event can be counted, and the rate of the condition can be compared for both vaccinated and unvaccinated persons. If a medical condition or symptom is significantly more common in the vaccinated group than in the unvaccinated group, this suggests the vaccine might be responsible. The gaps that exist in the scientific knowledge of rare vaccine side effects prompted the CDC to develop the Vaccine Safety Data Link, or VSD project, in 1990. The VSD project involves partnerships with 10 large health maintenance organizations to continually monitor vaccine safety. VSD is an example of a large linked database and includes comprehensive medical and immunization histories for more than 5 million people. All vaccines administered within the study population are recorded. Available data include vaccine type, date of vaccination, concurrent vaccinations, those given during the same visit, the manufacturer, lot number, and injection site. Medical records are then monitored for potential adverse events resulting from immunization. Since VSD includes medical records of both vaccinated and unvaccinated persons, rates of medical conditions can be generated and compared. The VSD project allows for planned vaccine safety studies as well as timely investigations of hypotheses. The database is also being used to test new vaccine safety hypotheses that result from the medical literature, VAERS, changes in the immunization schedule, or from the introduction of new vaccines. This project is a powerful and cost-effective tool for the ongoing evaluation of vaccine safety. We will include links to VAERS and additional information about the Vaccine Safety Data Link and other vaccine safety resources on our Updates and Resources webpage.
We would like to present a case study that addresses issues that we have discussed on this program. The case studies are available on the Updates and Resources webpage. Aiden is 20 months old and is an established patient in your practice. Aiden received MMR number 1, varicella number 1, DTaP number 4, Hib number 4, PCV number 4, and hepatitis A number 1 at 14 months of age. Aiden's mother reports that he developed a temperature of 101 degrees for 2 days, about 9 days after the vaccines. He had no other symptoms and did not require medical attention. At 17 months of age, Aiden was diagnosed with a neuropathy that caused weakness of his left leg. He was treated with a 2-week course of prednisone and ibuprofen. 3 months later, he still has residual weakness of his left leg. He has no other medical problems. Here are the questions about Aiden. Was the fever 9 days after his last vaccinations caused by the vaccines? If so, which vaccine was responsible? Was the neuropathy caused by the vaccines? Should the fever and/or the neuropathy be reported to VAERS? If you are viewing this program with a group, we suggest you pause the program now and discuss it among yourselves. We will return in a moment to discuss it with you. The Aiden case study is a situation we hear about often. A person receives a vaccine, then a medical event occurs. The provider is uncertain about whether the vaccine caused the adverse reaction and what should be done about it. Here is the first question about Aiden. Aiden had a fever about 9 days after he received multiple vaccines. Was the fever caused by the vaccines? Possibly. Fever is not common, but can occur after almost any vaccine. If so, which vaccine was responsible? In this case, the fever was most likely caused by the measles component of MMR. MMR and varicella vaccines can cause fever 7 to 10 days after vaccination. The timing of the fever relative to the vaccine gives us a hint about which vaccine might be the cause. Fever after live vaccines occurs after an incubation period of the virus. Fever following inactivated vaccines usually occurs within 48 hours of vaccination. Here's the next question about Aiden. Was the neuropathy caused by the vaccines? Well, it's hard to say if the neuropathy was caused by the vaccines. Neuropathy of the leg has not been reported after vaccination. Brachial neuropathy has been reported after tetanus-containing vaccine, but is rare. Also, the neuropathy occurred 3 months after his last vaccines, which also makes vaccination less likely to be the cause of the symptoms. Now, here's the last question about Aiden. Should the fever and/or the neuropathy be reported to VAERS? It is not necessary to report the fever to VAERS. Fever is a recognized adverse reaction following MMR and varicella vaccines. However, the neuropathy definitely should be reported to VAERS. The main purpose of VAERS is to identify what are known as signals, clusters of cases of previously unidentified adverse reactions that should be reported. The neuropathy may or may not be related to the vaccine, but you don't need to know for sure. When in doubt, send in a VAERS report. What we would like to do now is share with you a few of the common questions that we receive on these topics. Joellen, I'm going to ask you the first one here. We hear this so much that many providers are concerned about giving live vaccines to anyone in the household with someone who's, say, on chemotherapy or has had a transplant, or even bringing grandchildren over to the house, you know, if someone's been, if the child's been vaccinated. What do we need to tell providers about this?
Well, that's a really good question, Donna. We get this one a lot. And what we have to think about is where is the risk associated to the immune suppressed person, because really that's the person who's the most vulnerable right now. And we're most at risk from someone bringing the disease to that immune suppressed person. So actually by vaccinating the close contacts, especially when we're talking about little kids, vaccinating them is going to protect the child and is going to protect the immune suppressed person also from them bringing the disease. So you actually get to protect two people with one shot.
It's that barrier of protection there.
Yeah, an extra layer.
Yeah, absolutely. Okay, thanks. Andrew, why is zoster vaccine not affected by antibody-containing blood products?
Well, the zoster vaccine, the way it's manufactured, it has such a high titer of varicella zoster virus. And the reason for that is it's a vaccine to prevent reactivation of a disease that's already present. And so because it is in such high titer, such a high amount of live virus vaccine, there's no concern about administration of antibody-containing blood products with it.
So basically, Andrew, so that I understand this correctly when I go to explain this to someone else, you're saying that there's so much antigen in the vaccine that it's able to overcome any circulating antibody and still mount a response?
Exactly, that's right. It can overcome a response, the antibodies to varicella zoster virus that are in antibody-containing blood products. The amount of vaccine virus is so high in the zoster vaccine, it's 14 to 15 times the titer. It's so high that it does, it's not overwhelmed by the antibodies that are in the product.
Oh, good.
But you know, during the program, we talked about the fact that you don't have to worry about antibody-containing products with LAIV or rotavirus vaccines. Well, why is that?
Good question. It's different from zoster vaccine. For LAIV, and the way influenza vaccines are manufactured, and this applies to the live attenuated form as well, the vaccines changed every year. We rotate the virus that is in LAIV. And so the antibodies to influenza virus that are in antibody-containing blood products are likely to not be affected by that vaccine. Because the vaccine will be different every year. We rotate it, and it's a different strain in every year's vaccine. Another reason with LAIV is that the way the vaccine's administered, it's administered intranasally. Well, if someone receives an antibody-containing blood product, they're receiving those circulating antibodies into their bloodstream. And so a vaccine that's administered locally into the nose, the immune reaction and the immune response is generated in the nose, and so also would not be affected by antibody-containing blood products and the antibodies therein. Now, for rotavirus vaccine, it's kind of a similar reason as to the last rationale with LAIV. The vaccine's administered locally. It's a live vaccine. It's administered orally. The immune response occurs orally and so is not affected by the circulating antibodies that are administered into the bloodstream as part of an antibody-containing blood product.
Okay. Well, here's another one related to LAIV, Joellen, and that is, you know, nowadays people in the hospitals are really sick. So we often have people who are immune suppressed. They may be on chemotherapy. They may be transplant patients, that kind of thing. So there's concern still. People are nervous about healthcare providers getting LAIV because of that. What should we say about that?
That's a really frequent question that we get. And the answer is often more healthcare workers than what you think can receive LAIV. What you have to know about who's eligible for LAIV is you have to go back to the rules associated with the intranasal influenza vaccine, and that is a couple of questions that you can ask yourself to make it a little bit easier. The first one being, is the healthcare personnel, are they between the ages of 2 through 49, are they healthy and not pregnant? That means that they're eligible for that vaccine. And then the next question is about their work environment. Do they work with patients that are so immune suppressed, so severely immune suppressed, that those patients are in a protective isolation or a protective environment? If that's the case, then they can't receive LAIV. But if they work with other patients, such as in an emergency room or in a surgical unit where that patient is in a normal environment, ambulatory care setting, those people can receive LAIV. Persons who work, healthcare personnel that work with patients that are immune suppressed and in a protective environment, they should receive the injectable influenza vaccine.
Okay, thanks. Now, I hear this from really nurses more than anyone else, and that is, you know, sometimes we talk about ACIP off-label recommendations. And so I get the question, is it really okay for, you know, for them to do that, to give a vaccine off-label if that recommendation is not actually in the FDA product insert or product information?
Yes, it is okay to do that. The CDC makes its vaccine recommendations based on the guidance of the Advisory Committee on Immunization Practices, or ACIP. Now, the ACIP often makes recommendations that conflict slightly with the information in the FDA's package insert. But the ACIP, they are the vaccine experts. They're the immunology experts, and so they're the ones that are defining the standard of care. And so providers, whoever they may be, should be following the recommendations of the ACIP.
Now, Jo Ellen, as mothers and nurses, we know that breastfeeding is a good thing, right?
Right.
I mean, it provides antibodies, good protection for the baby, but what then about being able to vaccinate the child, or even if the mom were to need vaccines during breastfeeding? What about that?
Well, I think we can all agree that breastfeeding is a good thing, and we would like to promote mothers breastfeeding their children or their babies. And we often get this question that people are concerned, am I giving the vaccine and it's not going to work because of the antibodies that the baby receives when they're breastfed? And the answer is a really good one. It's the baby's going to be fine if the baby's vaccinated. Those antibodies that are received during breastfeeding are not the kind that are going to interfere with the vaccine mounting a response. And it will, the vaccine will still be able to mount that response, and the baby will still be protected. So mothers should breastfeed and babies should be vaccinated.
And mom can be vaccinated too if she needs it.
And mom can be vaccinated too.
Good, great. Okay. I think we have time for just one more question. And this one, Andrew, sometimes we talked about the fact that a person may have to receive several doses of the same vaccine in a series. So, and they may not always go to the same provider. So what if they go to a different provider and the provider looks on the record and they realize, well, we don't have that brand that you received for that series? What? Should they vaccinate them with what they have, or?
Yes, they should. They should vaccinate with the vaccine brand that they have. Now, the ACIP makes a recommendation that providers should try to use the same brand if they have it, the same brand as the doses received previously. But if they don't happen to have that brand, you don't want to miss an opportunity to vaccinate. So you can use a dose of a vaccine that's a different brand if you have to. Don't miss an opportunity to vaccinate. That's the key.
Well, thank you. I think that's all the time that we have now. Thank you, Jo Ellen. Thank you, Andrew. And thank you for being here.
This brings us to the close of this session of Epidemiology and Prevention of Vaccine-Preventable Diseases. We would like to remind you of resources that you can use to get more information or to contact us. Here's the companion book for this program. The book is a useful resource for any office that administers vaccines to persons of any age. The Public Health Foundation is the sole source for a printed copy. In addition to the print version, the 12th edition is also available in an e-reader format. You can contact the Public Health Foundation through their toll-free number at 877-252-1200. You can also order materials online from their website at bookstore.phf.org. If your patients or their parents have immunization-related questions, you can refer them to the CDC Info Contact Center. You can reach the Contact Center toll-free at 800-CDC-INFO. The CDC Info Contact Center is staffed from 8 a.m. until 8 p.m. Eastern Time, Monday through Friday. If you or your staff have questions, you should direct them to the National Center for Immunization and Respiratory Diseases by email. Our email address is nipinfo@cdc.gov. Throughout this program, we've mentioned several immunization resources. You can find links to these and much more on the Program Resources webpage at www.cdc.gov/vaccines. Click on the Education and Training section, then the Immunization Courses link. Choose this program from the list to find all the materials we've discussed in this session. It's a good idea to have the most current immunization information quickly accessible in your office or clinic. An easy way to do this is to have the information available on your computer. We've compiled all the current ACIP statements, vaccine information statements, the course text, and much more on a DVD called Immunization Works. It provides a great way to have all your current immunization information together in one place. The DVD is distributed free of charge by the CDC. The Program Resources webpage has a link to order it. Continuing education credit is available for viewing this program. Details about the procedure for obtaining CE credit can be found in the Continuing Education chapter of the DVD or on the Program Resources webpage. Thank you for joining us for this session of Epidemiology and Prevention of Vaccine-Preventable Diseases. We hope you'll join us for other sessions in this series. Until then, goodbye.